So if you ever look over the counter at your printed hospital discharge summary, before you leave, you probably won't actually see words.
Right. It's just a wall of letters.
Yeah, it's this wall of random capital letters scattered across the page.
Yeah.
It honestly feels like you're trying to decipher this ancient secret code.
I mean, that's exactly what it is. But when we talk about this code, what we generally call medical abbreviations and acronyms, we are actually lumping three very distinct linguistic tools under one umbrella.
Right. Three different things entirely.
Exactly. So first you have your classic abbreviations. These are created by just, dropping letters or relying on old Latin roots, like BID for twice a day, which comes from the Latin bis in die.
Okay, sure. That makes sense.
Then second, you have actual acronyms. These are initials that are just spoken aloud as their own word. So a really common one is CABG, spelled CABG.
Right, which stands for coronary artery bypass graft.
Yeah, but clinicians don't say all that. They just pronounce it cabbage.
Which, hearing that a patient needs a cabbage sounds totally bizarre if you don't know the code, right?
No, absolutely.
But functionally, it is safe. The cabbage thing isn't hurting anyone. The third category, though, is where the real systemic danger actually lies, right?
Yeah.
And that is dose designation shorthand.
Okay, explain that one.
So this includes the specific symbols, the spacing, and the conventions used for writing out numbers, units, and frequencies. So like writing QD for once daily, or noting a dose as 5.0.
Right, and clinicians rarely name this third category explicitly in everyday speech, do they?
No, not at all.
No.
Yet it is the primary culprit in major medication errors. The line separating an everyday safe shortcut from a dose designation abbreviation that literally causes a fatal error, it is razor thin.
Wow.
And over the last few decades, the medical community's understanding of that exact line has just undergone a radical shift.
So it's kind of like, well, moving to a new city means picking up the local slang, right? Just to communicate faster.
Yeah, but in the medical city, getting the slang wrong isn't just embarrassing. It is quite literally a life or death situation. So the mission for today's deep dive is to arm you with the medical shorthand you absolutely must know cold to navigate your own healthcare.
Yes.
And more importantly, we're going to explore the infamous do not use list. Because to understand why regulators literally banned certain letters, we first have to, look at the origins of this whole shorthand system.
Right. And you have to remember, medical shorthand is centuries old. Apothecaries and physicians were abbreviating Latin instructions all the way back in the Middle Ages.
Early the Middle Ages.
Oh, yeah. They used these specific esoteric symbols for measurements, like the ounce or the scruple, and they integrated them with Roman numerals. And that whole apothecary tradition, it survived almost completely intact right into 20th century American medicine.
So a doctor in, 1950, scribbling on a prescription pad was essentially just writing in medieval dog Latin.
Pretty much, yeah. They used terms like QD for quackdai, meaning every day, or PRN for pro re nata, meaning as needed, or stat from statum for immediately.
And this shorthand was designed exclusively for speed, right? Not safety.
Exactly. Speed was the only goal. It functioned as this totally private communication tool between two professionals, a doctor and a pharmacist who basically shared identical training.
Right, the old private club.
Exactly. It was never, ever designed with a modern, complex hospital system in mind.
So, okay, let's unpack this for a second.
Yeah.
Because if doctors and pharmacists used this Latin shorthand safely for literally hundreds of years, why did it suddenly become a massive crisis in the late 90s? Did handwriting just suddenly get worse overnight?
No. Handwriting didn't get worse. It's just that the modern patient safety movement finally exposed the cracks in that private club.
Ah, okay.
Yeah, so back in 1975, this pharmacist named Michael R. Cohen began actually publishing case reports on medication errors.
Right.
And by 1994, he co-founded the Institute for Safe Medication Practices, the ISMP.
Okay, the ISMP.
Right. And this nonprofit was built to systematically analyze reported medication errors and, push for actual systemic fixes.
Because before that, they were just firing a nurse or blaming a doctor for a mistake, right?
Exactly. It was all about individual blame. But the ISMP looked for patterns in the aggregate data. They relied on frontline workers to voluntarily submit near misses and actual injuries.
Okay.
And by aggregating those reports, the ISMP identified that specific recurring shorthand was just repeatedly showing up in the error files.
Wow. And that data pipeline led to a pretty massive regulatory response, didn't it?
It did. The real catalyst was this landmark 1999 report from the Institute of Medicine called To Err is Human. It basically reframed medical error broadly as a systems problem rather than a personal failing.
Right.
And by 2004, the Joint Commission, which is the accrediting body for U.S. hospitals, they made a strict do not use list a mandatory national patient safety goal.
Meaning accredited hospitals were just totally forbidden from using a specific list of abbreviations and handwritten orders.
Yep. Handwritten orders and free text computer entries.
See, the fascinating part of this timeline to me is that gap between centuries of use and then the sudden crisis. The profound conceptual shift here is that the system finally stopped treating an error as a moral failing or a personal screw-up.
Right.
Instead, they finally started treating medical abbreviations as a patient safety category. Basically an analysis of how shortened words mechanically fail in the real world.
Yes, because if you strip away the medical jargon, we are really just talking about basic geometry here.
Geometry.
Yeah, regulators had to step in because the physical shapes of certain letters were literally causing mechanical failures.
Wow.
And the single most notorious abbreviation in medicine, which tops essentially every do not use list out there, is just the letter U, used for the word units.
Okay, so if a doctor writes an order for insulin, jotting down 10U is highly efficient.
Very efficient.
Right.
But under time pressure, a hastily written cursive U often forms a closed loop at the top.
Oh, I see where this is going.
Yeah. That loop looks strikingly like a 0, or sometimes a 4. So a pharmacist reading that hasty handwriting sees a 10 and then a loopy U right next to it, and they process the whole thing as 100.
A prescription of 10U misread as 100 is an instant tenfold overdose.
Instant. The ISMP and the FDA have compiled multiple reported cases of this exact geometric collapse with insulin and heparin. And tragically, some of them were fatal.
Wow.
So the instruction across American medicine is now absolute. You must always spell out the word units.
It's literally a structural flaw in human handwriting. But the geometric failure of the letter U relies on bad penmanship, right? What blows my mind is that the regulatory boards realized there is a way to cause that exact same tenfold overdose with perfect penmanship, just by misplacing a tiny dot.
The trailing and missing zeros. This
Yeah.
is a classic ISMP teaching example because the failure mode here is purely arithmetic. So if a doctor wants to prescribe 5 milligrams of a drug and writes 5.0 milligrams, that trailing decimal point can just so easily disappear in transcription.
Hey, disappear how? Like, just get lost.
Yeah. It could be obscured by a smudge on a fax machine or a speck of dust on a scanner, or it could just simply be overlooked by a really tired eye at the end of a shift.
Oh, man. Here's where it gets really interesting to me. It's less like a typo in a text message, and more like missing a single semicolon in a computer program.
Oh, that's a great way to put it.
Because the doctor's intent is perfectly clear, but that one missing dot completely crashes the arithmetic. 5.0 silently becomes 50, delivering a tenfold overdose. It's a literal design flaw in the alphabet.
It really is. And the omission works in reverse, too.
Really?
Yeah, so if a doctor prescribes a half milligram and they write 0.5 milligram without a leading 0 and that tiny decimal point is missed, it is read as 5 milligram, another tenfold overdose.
Wow. So what's the fix?
The solution is strict formatting rules. You never use a trailing 0 after a decimal, and you always use a leading 0 before a decimal. Period.
Okay, so that handles the math. But stray pen marks cause just as much chaos with the old Latin abbreviations, right? Like if a doctor writes QDDD for once daily, the period after the Q, when written quickly, often drags down into a vertical line.
Exactly. Visually, it transforms into the dot and stem of a lowercase I. So the instruction QD becomes QID.
And QID stands for quarter in die, or 4 times a day.
Right.
So a single stray pen stroke turns a daily pill into a massive 4 times a day overdose.
Yeah. And we see similar mechanical misreadings with QOD, meaning every other day.
Oh, because of the O.
Yes. If the O gets sloppy or blurred, it is incredibly easily misread as QID or even just plain QD. So a patient expecting a drug every other day who instead receives it 4 times in one single day, that is just a straightforward mechanical misreading.
Which is exactly why the Joint Commission requires that daily and every other day must be spelled out in full now.
Exactly.
The complexity really compounds, though, when we move from dosage frequencies to actual chemical formulas, specifically MS, MSO4, and MGSO4.
Yes, this is a huge one.
Because MS alone is entirely ambiguous, isn't it?
Completely. It could indicate morphine sulfate, which is a powerful opioid painkiller. Or it could mean magnesium sulfate, which is a drug used for completely different indications, like preventing seizures in pregnant women.
But relying on the extended chemical formulas doesn't solve the problem either.
No, because MSO4 for morphine and MgSO4 for magnesium differ by only one lowercase letter, the G.
It's just a tiny lowercase g.
Yeah. And in hurried handwriting, that single letter is incredibly easy to transpose or overlook. So the ISMP's guidance dictates writing morphine sulfate or magnesium sulfate in full every single time. There's just no abbreviated form of these names that is reliably safe.
So the common thread here is that when the shape or the sound of an abbreviation visually overlaps with a totally different instruction, one that carries a different dose, the system fails.
Exactly.
And if the alphabet itself is causing tenfold overdoses, the obvious instinctive response is, why don't we just ban all abbreviations? But the Joint Commission only bans, what, about half a dozen?
Right, because a global ban is practically impossible due to the context trap.
The context trap.
Yeah, meaning changes based entirely on which room of the hospital you're standing in. So the letters OD in an emergency room triage note or in a psychiatric chart universally mean overdose.
But in an eye clinic, ODD means oculus dexter, Latin for right eye.
Exactly. And in a pharmacy, especially in older conventions or outside the US, OD is often used to mean once daily. So you have one string of two letters that contains three completely live, vastly different meanings depending entirely on the specialty.
That is a disaster waiting to happen. And the eye clinic example introduces auditory failures too, right? Because eye drops are prescribed using OD, OS, and OU. Right eye, left eye, and both eyes.
Right, and eardrops are prescribed using AD, AS, and AU, from the Latin oris for ear.
Right, and the letters A and O look almost identical when written in cursive. Plus, they sound super similar when spoken aloud in a busy, noisy hospital ward.
Yeah, that mix-up between AD, AS, AU, and OD, OS, OU, has actually led to documented cases of medication being administered into the wrong orifice.
Oh, wow. Okay, but still, why not just ban them? I mean, why do clinicians push back against a blanket ban so heavily?
Because speed is frequently a clinical necessity. Look, nobody is going to write out myocardial infarction during a code blue. When a patient is actively crashing, the team must communicate and document using terms like MI, STAT, CPR, and DNR.
Right.
Forcing an ICU nurse to spell out every single word drastically slows down documentation, and that creates an entirely different kind of danger for the patient.
Okay, so that makes sense. Patient safety advocates had to tailor the ban really narrowly.
Yeah.
They only banned the specific abbreviations proven to cause severe repeated geometric or arithmetic harm, like the U for units or the trailing zero, but they left the vast vocabulary of essential medical shorthand intact.
Exactly. And to deal with the rest, hospitals have poured billions of dollars into electronic health records, EHRs. They use computerized physician order entry systems to basically just sidestep the handwriting debate altogether.
Because moving to typed orders and drop-down menus means a typed U will never look like a zero.
Right, the geometry problem is solved.
But wait, so what does this all mean for the tech side? We built these billion-dollar electronic record systems to get rid of handwriting. Did we just trade bad penmanship for bad autocorrect?
In many ways, yes, we absolutely did. We built these systems to eliminate visual misreads, but we introduced entirely new failure modes through user interface design.
Ah, of course.
Autofill is a primary new hazard. A clinician types the first two letters of a drug, and the computer generates a drop-down list. If they're moving too fast, maybe they're suffering from alert fatigue or cognitive overload.
Which they always are.
Exactly. And they click the adjacent item on the list. Boom! They prescribe the wrong drug. Additionally, the ease of copying and pasting yesterday's notes into today's chart often carries forward stale abbreviations that no longer apply to the patient's current condition. So the machine eliminated the cursive overlap, but human error just adapted to the new interface.
Since technology isn't a perfect silver bullet, the medical field has had to invent other structural frameworks, right? Safety nets to catch these mechanical errors before they actually reach the patient. Because if abbreviations confuse individual letters, there is a parallel problem that confuses whole words.
Yes, LSA. Look-alike, sound-alike drugs.
Right.
Drugs like hydroxyzine and hydrolazine sound incredibly similar on a busy floor, and abbreviations just exacerbate LSA confusion. If a clinician abbreviates hydrocortisone and hydrochlorothiazide down to just HCT, they strip away the very syllables that were engineered to distinguish them from one another.
So to combat this LSA confusion, hospitals deploy this brilliant visual countermeasure called tall man lettering.
Yes, tall man lettering is great.
Instead of shortening a word, You visually stretch out the most important distinguishing part of it. So when dealing with dopamine and dobutamine, the labels actually capitalize the DOP in dopamine and the DOBUT in dobutamine.
Exactly. It's basically an engineered cognitive interrupt. It breaks the visual pattern of lowercase text, and it forces the clinician's brain to pause and actively recognize those differentiating letters. It is a structural guardrail against human fatigue.
It's like putting up a giant neon sign at a blind intersection to force you to pay attention.
Exactly. And since we know the letters themselves fail, the hospital also relies on frameworks like SBR to wrap those letters in a protective layer of context.
For SBARU.
Yeah, it stands for Situation, Background, Assessment, Recommendation. It forces clinical handoffs to follow a really rigid, predictable structure.
So if a nurse just shouts an abbreviation down a hallway, the context is totally stripped away.
Right. But by using SBR, the nurse must systematically deliver the background and the clinical assessment first. So by the time they finally use an abbreviation, the receiving doctor has enough surrounding information to understand the actual intent.
Oh, I see.
Yeah, the structure provides the context needed to know whether OD means the patient had an overdose or if it refers to their right eye.
So the do not use list standardizes the vocabulary of the hospital,
Right.
while SBR standardizes the structure of the communication itself.
Yes.
And there's another critical safety net too, right? Medication reconciliation.
Oh, this one is huge. This is the formal, systematic process of cross-checking a patient's medication list at every single transition of care. So when they move from the ICU to a step-down unit or from the hospital to home.
Because without it, transcription errors just compound.
Exactly. A missing decimal point on admission could theoretically carry through every chart update for a whole week. By forcing a hard stop to reconcile the list against the original orders and the patient's history, the system aims to catch those mechanical misreadings before discharge.
Looking at all these systems really helps clear up a couple of major misconceptions about how medical errors actually occur. The first misconception being that the Joint Commission banned all medical abbreviations.
Right. The official mandatory list is actually very short. It's roughly 6 items, mainly targeting the U, the QDs, the trailing zeros, and those MS formulas. Thousands of other abbreviations remain standard.
And the second misconception is the assumption that errors happen because doctors or nurses just lack knowledge.
Yes, that is a huge misconception. It is incredibly rare that a clinician simply doesn't know the proper dose of a common drug. The failure is almost entirely visual or auditory misreading under immense time pressure.
Right. It's like thinking car crashes only happen because people forget the rules of the road rather than realizing it's a poorly designed blind intersection.
That is spot on. The regulatory fix is to spell it out because literally no amount of medical knowledge in the doctor's head prevents a smudge on a fax machine from hiding a decimal point.
So bringing this all back home, all these systemic hospital fixes, these internal medical debates, how does this actually impact you, the listener, when you are handed your own paperwork to take home?
Well, it impacts you directly because every prescription and every discharge summary is still totally saturated with acronyms. Your discharge sheet isn't going to spell everything out beautifully. It's going to say something like follow up on CBC, BUN, HTN, and DM.
Which basically leaves you guessing unless you know that CBC is your complete blood count. BUN is blood urea nitrogen, a metric for kidney function. HTN stands for hypertension. And DM is diabetes mellitus.
Right. These are standard, perfectly safe abbreviations in the medical community, but to a patient, they are an impenetrable alphabet soup.
Yeah.
So reading your own chart is a vital health literacy skill. You really need to know how to navigate this terminology to protect yourself. Like, if your chart says NPO, it means nothing by mouth. You cannot eat or drink before your procedure.
And PRN, that's another big one.
Yes. A medication marked PRN means as needed. It is not mandatory. You only take it if you actively have the symptom it treats, like pain or nausea. Taking a PRN medication as if it were a scheduled daily drug will lead to severe complications.
But perhaps the most dangerous abbreviation for a patient taking paperwork home is just a lowercase d, a slash, and a lowercase cd/c.
Yes. In a hospital context, DC is dangerously ambiguous. It can mean discharge, as in the patient is going home with this list of continuing medications, or it can mean discontinue, as in stop taking these medications immediately.
Imagine standing in your kitchen, holding your discharge papers, and you see DC next to all of your vital heart medications. As a patient, you absolutely need to know if your doctor is telling you to stop taking everything or just summarizing what you were discharged with.
It's terrifying. Misinterpreting DC at home is a highly documented source of post-hospital medication errors.
So what should a patient do?
You have to ask for clarification before you leave the building. If you see a trailing zero, an ambiguous letter, or an unexplained acronym, you must act as the final safety check. Never assume you know what the abbreviation means if it dictates how you administer your own medicine.
So when it comes to medical shorthand, ambiguity, not a lack of clinical knowledge, is the real danger. We've traced this incredible journey from ancient Latin apothecary secrets designed entirely for speed to the modern do not use list designed to prevent mechanical failures.
Right.
A single missing decimal point or a loopy cursive U has the power to cause a silent tenfold overdose. And context dictates meaning, making an OD in an eye clinic fundamentally different from an OD in the ER.
Exactly. The rules of language just have to adapt when the stakes are this high, because medical language is essentially an evolving technology. We moved from quill pens in Latin to cursive shorthand to computerized drop-down menus, all attempting to engineer out the mechanical flaws in how we communicate.
And if medical language is an evolving technology, we are right on the brink of the next massive shift. Because artificial intelligence is beginning to integrate into electronic health records right now to auto-generate patient notes and summarize complex charts.
Which leaves us with a really critical, unanswered question for you to mull over. Will an AI system understand the nuanced, deeply human context of an abbreviation like OD better than a nurse at the end of a 12-hour shift? Or, by handing the transcription over to a machine learning model, are we on the verge of inventing an entirely new, invisible set of algorithmic errors that we won't even discover until the next generation's do not use list?